Hi, welcome to week 5 of 8 Beats to Better Outcomes. This week is all about contractions. For the people that have been on our training recently, you will know that this is an exciting one for me. Don't worry, I know how sad that is. So for this change, what NICE has done is make contractions a feature of CTG classification rather than just a consideration, and it makes a lot of sense. So why has this change happened? What was wrong with that little box in the top right-hand corner of our stickers that asked for what the contractions were doing? Well, as we know, everything that happens to the uterus has the potential to impact on how baby is coping. During a contraction, the placental function is temporarily interrupted. If the contractions are too frequent and lead to less resting time in between, this means that baby spends less time being able to exchange gases, which can lead to acidosis. And remember, each baby is very different and will have different reserves and in turn will cope differently with these contractions. So what is NICE actually now saying? Well, less than 5 contractions in 10 minutes is a white feature. This means that if there are no amber or red features, the CTG is normal and suggestive of a baby that is coping. If contractions are 5 in 10 or more and leading to reduced resting tone between, or if contractions are lasting for 2 minutes or more, then this is an amber feature. And even when all other features are white, this would be a suspicious CTG. So what does this mean for practice? It does not mean that all women who are contracting more than 4 in 10 need intervention. But what it does mean is that contractions that are 5 in 10 or more should prompt us to consider the whole clinical picture, rather than waiting for other CTG changes and then having to fix a problem that we could have prevented. If contractions are too frequent or lasting too long, we have options to enable baby to continue to cope with the ongoing labour. The rate of any oxytocin infusion and whether it needs to be reduced or stopped, and terbutaline should be considered. Remember, each baby is going into labour with different reserve. For those that are term, well-grown and in spontaneous labour, contractions may be 5 in 10 for some time before baby starts to show any compensatory methods. However, a baby that is being induced at 37 weeks for fetal growth restriction and raised PI values may deteriorate much quicker. As with all the changes to this guideline, it is vital that we consider the antenatal and intrapartum risk factors and the whole clinical picture whenever we are looking at the CTG. I know for some people this feels really obvious, but we know that from local and national investigations into poor outcomes, hyperstimulation remains one of the big causes of those poor outcomes. And unrecognised hyperstimulation is still happening both locally and in the bigger picture nationally. Furthermore, from auditing our local Fresh Eyes process, contractions are frequently not discussed when the CTG is being looked at. So this change is going to really highlight the importance and help us to remember that contractions are a part of CTG interpretation, along with the wiggly line of the fetal heart and the whole clinical picture. And remember, contractions should be palpated. Relying on the CTG TOCO alone does not give you a good idea of strength and resting tone between those contractions. And when we're talking about the time that baby is able to exchange gases during that resting tone, it becomes really, really important that we know for sure what is going on, particularly when we are titrating oxytocin infusions.